I'm Dr. David Bernstein. Welcome back to our latest series, 7 Secrets of Forensic Schema Therapy. Now, last time we talked about the fact that in doing forensic work, we're usually operating in a situation of incomplete information, and that has a lot of implications for how we do forensic schema therapy. And today I'd like to talk about a second secret of forensic schema therapy, and that is that love is not enough. Now, as therapists, we're usually pretty well trained to be empathic and to be attuned to patients. And these are things that usually come naturally to us, otherwise we wouldn't be in this field. But setting limits and boundaries is something that may not come as naturally to us. And for many of us, it's something that we need to learn. We need to be trained how to do that and when to do it. And the reason for that, this may not come up so often in general practice, but it certainly comes up quite frequently in doing forensic treatment. Because when it comes to doing forensic therapy, and forensic schema therapy in particular, we really need to provide simultaneously for two of the patient's unmet emotional needs. One is the need for attachment, and the other is the need for limits. And, these may seem contradictory, but let's talk about them a little bit. In schema therapy, schema therapy is an attachment-based form of therapy. And in particular, it's a form of therapy that focuses in on the patient's unmet emotional needs. And as the therapist, we try to provide for those needs to at least a partial degree in the therapy relationship. And that's what we call limited reparenting. Now, when it comes to forensic patients, this is crucial because many of them never experienced a secure attachment relationship. Instead they grew up often in violent homes, unpredictable homes. They were neglected or abused or abandoned. And so, by providing that kind of, consistent, caring and opportunities for closeness and predictability and authenticity in the therapy relationship, we are giving them something crucial that they missed growing up. But another crucial thing that they missed were limits. Now, either these patients may have come from families or situations where there was a complete lack of limits and boundaries. Maybe the parents were unavailable, maybe due to their own problems, or they were sent from one environment, like, one, foster home to another, or one relative to another, where the kinds of limits they experienced were very confusing and unpredictable, or sometimes they experienced harsh, punitive, or even abusive, quote, limits. Those aren't what I would really refer to as limits. They're more like, various forms of punishment. But what they didn't get to experience was, having, parental figures who were able to go and set limits with them in a clear, constructive, and healthy way, and do this on a consistent basis. And, when I think about, the patients that I've worked with over the years, one person who really, helped me to understand this issue was a patient from many, many years ago when I was a young psychologist working at the Veterans Hospital in the Bronx, New York. And one day in therapy, he said to me, when I was growing up, no one ever cared enough about me to say no to me. Okay, so he experienced that as something crucial that he had missed out on in his own upbringing. And why is that important? Well, first of all, one of the ways in which children learn self-control is by internalizing limits. When we say no to them out of caring, but in a firm and clear and consequential way, over time, they internalize those limits. And that helps them, ultimately to set limits on their own behavior, to develop self-control. And another reason why limits are so important is that limits also bring safety. Unfortunately for many forensic patients, they grew up in an environment where there was no parental figure who could really keep them safe. And limit setting also has the function of showing a child, where the limits are of their own behavior. That if you cross this line, that's dangerous. And so, many of our patients grow up in a world that lacks safety and where there's no one there who's strong enough and caring enough to protect them, including by saying no to them. And so what do? Well, they kind of step into that void themselves. They say, well, there's nobody here strong enough or caring enough to protect me, so I've got to do it for myself. I'm the only one whom I can trust. And they often develop all kinds of, overcompensatory ways of coping, what we would call, overcompensatory modes to protect them, like, being dominant and being aggressive, or being manipulative, or even predatory. Okay, so the lack of limits then causes them to step into the void and develop modes that end up causing very serious problems for them and for other people. Okay, so we need to be able to provide both of these things, even though it may feel like a bit of a contradiction. On the one hand, to be caring and warm and available, but at the same time, firm and clear and consequential. We need to really be able to do both of these things for our patients. Now, what are the kinds of situations where the need for limits comes up, particularly in forensic work, although also sometimes in non-forensic work? Well, there are really two kinds of situations. One is when the patient has therapy interfering behaviors, or to put it differently, modes that get in the way of the progress of therapy. And the second situation has to do with boundary violations, when the patient's modes violates the therapist's boundaries, or violates other boundaries, in his environment. So let's talk a little bit about, each of these and take an example. Okay, so here's a mode that we introduced last time, the angry protector mode. And as we noted last time, that mode can make it really difficult for us to get close to the patient, to provide that kind of attachment relationship, because it sends a very clear nonverbal message that says, stay away from me. So this is a mode, you could say, that interferes with treatment. Now, as we noted last time, the patient does it really because, that's his comfort zone. This provides for his sense of safety, right? Because of deep feelings of mistrust, and as I just touched upon, many of these people feel unsafe. They feel unsafe in therapy. And so they use different kinds of modes to protect themselves. Okay, so this is an avoidant mode that, protects the patient. And even though we can understand it, and we may have some empathy for it, it still can cause big problems in terms of moving forward with therapy. Now, under normal conditions, the way that we work with these kinds of therapy interfering modes is by using a technique called empathic confrontation. We, kind of hold a mirror up to the mode, by, showing the patient, the mode that he's in real time, and doing it in a clear but empathic and understanding way so that he can sort of take in that feedback that we're giving him. But sometimes empathic confrontation is not enough, particularly when, modes are very, very serious and entrenched. And if we don't actually set a limit on the mode, it can actually disrupt the therapy and, to an extent that can make, progress impossible. And one of the situations in which, I discovered this and my colleagues discovered this many years ago, was in a case that I discussed last time of a, therapist who had a patient who had this mode very strongly and for many months refused to make eye contact with her, only answered her questions, with 1 or 2 word answers. Okay, so here's a clear example where the mode, if it was not dealt with, successfully, would essentially, render therapy useless. And so at a certain point, the therapist, was so frustrated from the feeling of helplessness that this, engendered in her, that she came into supervision literally in tears, and we talked about it. And what, we decided in our supervision group is that the therapist needed to set limits on this mode. And in the next session, the patient came in and the therapist essentially said to him in a respectful but very clear way, hey, this side of you is making it impossible for me to work with you. And, you're going to have to make a choice. Can you let this wall down a little bit so that I can see the person behind this wall? Because otherwise, I'm not going to be able to work with you. I can't help you. And the patient, was quite shocked at this, but, it's not, I guess he hadn't experienced this before. But the next session he came in and he agreed to do what she, had, said she expected or needed in order to continue to work with him. And he actually, followed through with what he said. He was able to lower that wall a little bit. They kind of negotiated about how much he would share with her, at least to start with. And then the therapy started to move forward. And ultimately, it was a successful therapy. So the limit setting on a mode that interfered with therapy, turned out to have a crucial role. Now, let's talk about the second kind of situation, boundary violations. Now, that's a big topic, because there are different kinds of boundary violations. Boundary violations that involve, a threat to someone's safety, right? Crossing boundaries in a way that leaves people feeling intimidated or frightened or threatened, or, actually, involves a literal threat to their safety. And we have other kinds of boundary violations also that include, violations, to therapists' rights to be treated in a respectful way, and so forth. But let's talk a little bit about, what happens when modes cross therapist boundaries in a severe way. If the boundary violation is not so severe, then we can use empathic confrontation and hold a mirror up to that mode. And let's take this example. This is the conning manipulative mode. What happens when, a patient tries to con the therapist? Well, again, you can hold that mirror of empathic confrontation up to this mode and, sort of point out in a, clear but empathic way that there's a side of the patient that is trying to con or manipulate you. But sometimes that's not enough because the boundary violation is more severe. And let's take an example. Imagine that there is, a therapist, imagine it's a, younger therapist and her patient, let's say a male patient, in a particular session, starts professing his love for her. Now, how would we deal with this in forensic schema therapy? Well, we always ask ourselves the question, which mode is involved in this kind of situation? And, this is a kind of boundary violation, a kind of, rather than staying within the constraints of the therapeutic relationship, which is, after all, a professional relationship, the patient, in essence is, asking that relationship be something more than that. Well, how we would deal with this and which technique we would use depends on which mode is involved. Let's say that the patient is somebody who, has developed these feelings out of genuine, vulnerability. Let's say that the patient missed out on a lot growing up and starts to experience, genuine feelings of love or, physical attraction, which is mixed up with, maybe romantic feelings. And it may be quite confusing to the patient or frightening to the patient. And in that case, what we're probably talking about is, what we call in schema therapy, a child mode, a mode that expresses, basic emotional needs and involves basic emotions. And so in that case, it would probably be easier for us to deal with this if we notice that the patient is coming to us and not crossing our boundaries, and not trying to be a lover boy or a Don Juan, but coming to us in a genuinely vulnerable way and expressing the fact that, he's developed feelings for the therapist. And there we may want to handle it in different kinds of ways. We might use some limited reparenting to, try to, essentially tune into the unmet needs, while at the same time providing some clarity, which is a kind of limit setting, about what the nature of the therapeutic relationship is, and that it's not unusual for patients to sometimes get confused about that, especially when a patient is being very warm and emotionally available to the patient. Okay, so that's the easier kind of situation. But what about when the patient is, let's say, where this, expression of love is really an attempt to con or manipulate the therapist. Maybe the patient wants to turn it into a sexual relationship, or, develop a certain kind of, quote, intimacy, or kind of fake intimacy with the therapist to use her or exploit her in some kind of way. Okay, this is a more difficult situation to deal with. Now, we can use the technique of empathic confrontation here. We can hold up a mirror and say, hey, I see a side of you right now that's trying to turn this relationship into something more. Okay, so that can be a very useful technique. But in some cases, when these violations are, more severe, and particularly, let's say, in patients who, imagine this a case of a patient who's more psychopathic, or a patient with a history of sex offenses, where this may represent a kind of what we call offense paralleling behavior, right? Where you're seeing the modes in the sessions that mirror the patient's, antisocial or criminal behavior. In that case, we may need to set limits. And in this case, we're going to set limits in a very clear and consequential way. We're not going to really have any ambiguity in how we set those limits. That doesn't mean that the therapist is going to, be, punitive toward the patient or retaliate against the patient. But the therapist needs to take much more of a business-like stance toward the patient and make it very clear, hey, this side of you right now that wants to, get into a relationship with me, I want to make it 100% clear that this can never happen and it will never happen. Okay, that's the degree of clarity that needs to be involved here. Okay, so maybe this illustrates, the difference between when the patient is, quote, falling in love with a therapist out of unmet needs, where is it really more of a genuine expression, versus when there's a manipulative mode that crosses the therapist's boundaries in quite an exploitative way. Okay. Now, what's the takeaway message here? The takeaway message is that, boundaries provide safety. This is something that patients need, and to not provide it in the therapy is something that actually deprives patients of something that they need. And it also, provides safety for the therapist, right? The therapist is just as entitled to be safe in the relationship as the patient is. Okay, so it's really a combination of providing for attachment needs and providing firm, clear, and consequential limits. Okay. Now, for more information about forensic schema therapy, about courses that we're going to be giving, and about supervision in forensic schema therapy, please write me at info@safepath-solutions.com. And to learn more about the images that you saw, the iModes images in this video, please go to our website, www.imodes.com. Have a great week and see you next time.